the learning curve in hip arthroscopy. So it's a long learning curve, it's steep, and that's all. Okay, a little bit about me. I'm from Israel, studied medicine in Israel, did residency in Tel Hashomer. It's a level 1 trauma center. Then I did a mini shoulder fellowship also in Israel. And then I was with Dr. Dom for 2.5 years in Chicago. And then went to Stanford for another year in sports medicine with Dr. Safran. So my serendipity was that Perry, my chief from the shoulder fellowship, knew Dr. Dom, and here they are. And it was a match, and it was a good match. And as I said, we're talking about shoulders and hips, so Dr. Safran keeps saying that the shoulder is just this plastic hip. So basically the outline of this presentation will be history of hip arthroscopy, challenges, tips and pearls, the learning curve, and how to choose your first case. So first of all, hip arthroscopy is not a new idea. It was first published by Dr. Borman. He did about 90 various joint cadaver arthroscopies. 20 of them were hip arthroscopy. And he did that in he did that in New York. So that's the instruments he used. They don't look very different than what we use today. Only didn't have a camera, so he had to use his eye on the end of the scope. So the first challenge is the skeptics challenge. We heard Dr. Dom talk about that. Many people can say, hey, hip arthroscopy is a procedure looking for a disease. Basically, it's not a very new procedure. In 1913, Volpius and Soffel described the procedure to reshape the residual bony deformity following Skiffy. And this is from 1936. We've seen this slide yesterday. Dr. LaRue showed that. So he designed this procedure basically to restore the range of motion. And while he was doing that, he was doing mainly the acetabular side. He was kind of afraid that the femoral side is not possible. I guess he was also afraid of AVN. So he, like Michelangelo, used an osteotome. And he says that he did 8 patients that had malum coxas senilis, means osteoarthritis. 2 of them had old Skiffy, and 1 of them had intrapelvic protrusion acetabuli. All of them were kind of very happy, and he was very happy with the procedure. I think he kind of chose the wrong patients. That's why it didn't last. And basically, a couple of years, a few decades later, we had total hip replacement for that. So that's the reason this procedure didn't last. In 1991, Raymond Gantz coined the term FAI, femoral acetabular impingement. He found that after a PAO surgery. Later in 2001, they published the open surgical dislocation technique for treatment of FAI, which is also a very good technique that doesn't create AVN of the femoral head. So basically, we're talking about like all diagnosis with a new name, like pistol grip deformity. Everybody knows that from residency. That's actually chem impingement. Coxa profunda can be called many times a pincer deformity. And malum coxa senilis, we call it today, osteoarthritis. Labral tear is also not a new diagnosis. 1977, Altenberg is doing surgery for 2 inverted labrum, and both were successfully treated and happy after surgery. So the challenges in hip arthroscopy, the way I see them, first of all, we have to to make the right diagnosis, we have to choose the correct treatment. So surgical indication is very hard in hip arthroscopy. The manual hip arthroscopy is learnable. Everybody can learn to do hip arthroscopy. Patient positioning is very important. It's one way to reduce complications. You have to learn, and this is the reason you're here, to access the hip joint. It's kind of hard to use the 70-degree scope. we must avoid complications, and you must also teach your team not to be afraid of hip arthroscopy. So, Dr. Bird say that even a perfectly performed procedure for the wrong diagnosis will always fail. So we must rely on history and physical examination, do all the measurements we talked about, center edge angle, crossover sign on X-ray, do diagnostic injections. I didn't hear anybody speak about diagnostic injection, but they're very important. We can define between a back problem, and actually Dr. Dom spoke about that yesterday a little bit, between spine problems and hip issues. And of course MRI, although it's for the patient, but it's also for us to design the surgery. Patient positioning is very important, that you know how to position the patient, that you have some kind of a chart. If you do that in Israel, they have that in Hebrew. But make sure that the patient, the team knows how to position the patients, that you are familiar with the table, that you have a well-padded post, that you secure the feet very well. The last thing you like to have is the feet go out of the traction, and many people have that at the beginning of the hip arthroscopy. If your scope is in the joint and you're losing traction, that is a disaster. So make sure the feet is well secured. And beside that, when you pull the hip, Dr. Dom asked you to say, make sure you have 3 things in your hand. And you can look Derek over here. He's kind of concerned. So safe access to the joint. First of all, you want to avoid scuffing of the femoral head. It's very easy to scuff the femoral head, especially with a 70-degree scope. The blind side of the scope is where you scuff. You don't see that. It's very, very easy to scuff. You wouldn't like also to go through the labrum. It's very easy to enter the hip joint. It's also a challenge not to damage it. So try not to, and almost everybody, and if you look on the videos here, almost everybody in one of the videos, not the one I edited because I deleted them out, but everybody almost have scuffing of the femoral head. It's very common. We published 2 papers about the safe side, the safe technique of accessing the hip joint. Basically, on shortly, what we want to do, we're using the bevel side of the needle as the safe side. So if you have the bevel side, the safe side towards the labrum or towards the femoral head, then you kind of slide on that instead of poking into that. 70-degree scope. These are real images of a light source through the scope. So you can see that 70-degree scope is looking downward, almost 90 degrees. And the 30-degree scope is looking forward, so it's not very intuitive to look at that. I think of that as the difference between swimming breaststroke and crawl. So you either look forward or to the side. So what I suggest is try to play with it outside. It's not intuitive. You don't back out with a scope. So you can play with it outside even before everything is ready. Things that helped me, Dr. Dom threatening me that he will kill me if I injure the labrum with the cartilage. And most important, if you get your hands on a model, that's very helpful. You can play with it, especially with a 70-degree scope, and getting the second portal on the model is very easy. It's not a very good one to repair the labrum, but to get around it's very good. And the best thing is courses like that and going to the lab and practicing. So I want to speak about general hip arthroscopy learning curve, or we call that hip arthroscopy evaluation. Not evaluation, evolution. That's a mistake, type 1. So basic pain generation, evolution. So at the beginning there was only idiopathic osteoarthritis and trochanteric bursitis. 1974, Ratzlaff published paper about piriformis syndrome. 1977, Altenberg, labral tears. 1997, Villar, ligamentum teres teres. Also in 1997, Bonker, gluteus medius. 1999, Gantz publishing the FAI, the femoral subtle impingement. Around the year 2000, Ferguson talking about liberal tears and how they're important for the stability of the joint biomechanically. 2008, enterinferring AAS impingement by Pan from China, and in 2009, ischiofemoral impingement by Berdella. So there's more than just impingement. Keep changing, keep developing all the time. Arthroscopic procedures also developed over time, from house cleaning to abdominoplasty and chelectomy, from labral debridement only to refixation and reconstruction, from trochanteric receptomy to gluteus medius repair, and ligament teres debridement to reconstruction. So I just did a small survey around 7 surgeons around here that doing hip arthroscopies. I asked them to give rating from 1 to 5 about the procedure they do, and which procedure they think is the most difficult. Basically, you can see that labral debridement, ligament teres debridement, the simple labral repair are kind of the easiest ones. The hardest ones are femoral osteoplasty, gluteus medius repair, and capsular application or closure. We also did some study about the learning curve with Dr. Dom on his first cases. So this is a kind of the same study Dr. Dom showed yesterday. He didn't show this slide. What we can see here is that the spanning of the alpha angle after the osteoplasty that he did. So the first 45 cases, you see, there were some patients that he did osteoplasty so distal that when you measure the alpha angle, there was still 95 degrees of alpha angle. And after 45 cases, you can see that the spanning of the alpha angle was much lower. And in the red dots over here, the cases that were done open. So when you do the cases open, you use the template. Most probably you'll get a very nice alpha angle. This is the learning curve of his first 130 cases. Basically, that was after he did his fellowship. He had quite a lot of experience, and you see that. I guess he started with the more easier cases, so he went down, and around after 74 cases, he also started to improve, but the improvement wasn't very significant. So basically, if you're getting ready, if you know what you do, you get good results almost from the beginning. So how to choose your first case? So that was her first case, and that was actually a gunshot injury. 22 years old, that was shot by her husband. Very bad case to start with. The hip was filled with blood, all hemarthrosis. It was kind of hard to do the second case, not for beginners. I would recommend try to avoid any kind of difficult procedures, avoid femoral osteoplasty, avoid capsule application in the beginning, avoid any kind of difficult patients. I think females are easier than males. It's easier to distract females. Avoid morbid obesity, unless if you live in Chicago, you have to. Difficult access. If you have patients with osteoarthritis, if you have large pincer, it's hard to access the joint, and if you have gunshot injuries. So goals for the first case. First of all, keep traction less than 90 minutes or even less than 60 minutes. You know you'll have less complications, your staff will be happy about that, they won't be afraid in the next cases about hip arthroscopy. Aim for labral debridement, and then that depends on how quick you do. If you can do only debridement. Your first case is one of the places where you can check the system, check that you know the tables, check that you have all the equipment you need. And of course you want to create good impression on the staff. They think, okay, he did hip arthroscopy in 90 minutes, yay. And then use existing resources. So there are many books. I really love this book, the Tom Bird Operative Hip Arthroscopy. I think it's a great book. You have everything in there. You have the Arthrex website. You have many courses like this one in the OLC. You have the observership. You can go to see Dr. Dom operating, or you can join him for a couple of weeks. Of course, then you can do a longer fellowship and eventually just be careful, don't damage the joint, and